At the outset, I think I must congratulate the young Turks of Jupiter Hospital who have organized this very novel course, fantastic sort of theme. When I was told about that theme, I never thought that it will be, it'll roll out to be so good. Thank you very much. A topic of, normally in any talk, I generally, or anybody generally doesn't want to take names of various companies and various models available. But a topic like this, generally it is not possible to complete without taking names of various implants. So by trying to stick a lot to only science rather than taking names, we still go ahead and see how we go. Whenever we do any replacement, we get bombarded with various papers given by company reps typically, telling good points about their implants and how they are superior to the other. Obviously, it is we who need to read in between lines and use our wisdom to see that good particular point in their implant. Is it sort of there along with some bad point, or what we need to be wary about? So various implants are available to us. I'm just sort of trying to take the commonly used ones. If the list is endless and it is going to ever increase, I think. But before we go on to see the good and bad points of various implants, it's very important for us to understand that we must use survivorship criteria before we select an implant. Any implant that we use should have about 96% survivorship in a 10-year follow-up. In average hands, good number of times, a implant which is used by the innovator will give you a fantastic outcome, but it is used by an average surgeon like you and me may not have the same outcome. So registries, I think, are a very good tool to see which is good and which is bad, and most registries actually are giving an average registrar level surgeon's outcome for any implant, and any implant which has a 96% survivorship for 10 years is good for us. Generally, once that implant has stood the test of survivorship, let's see what other points we look for. A brief talk on unicorn knee. I think in a unicorn knee, the patient selection is more important than implant selection. Generally, a patient with anteromedial wear rather than a sort of tri-compartment or global wear with an intact ACL without any fixed deformity will do very well. So patient selection is more important than implant selection. In case of certain femoral implants, you would be told that this has an oxenium, and generally oxenium or a ceramic in industry is giving good result. It is showing promise as far as the wear is concerned. And in laboratory studies, some of the oxenium implants have shown almost 30 years follow-up. And I think it is a good implant, especially for those Google searched young patients who come and tell you that, doctor, what about oxenium? We have seen that in the literature it is doing well. So I think it's a good option to use in such patients, especially if they are young. Highly cross-linked poly also gets talked about quite a lot. In the literature, you will probably not get as much support for highly cross-linked poly because it has certain good points, but in abrasive wear and adhesive wear is less. But generally, it is not necessary that they will last longer than a normal poly. But what I've observed is most implant companies are slowly now shifting to highly cross-linked poly, and probably in another 5 or 10 years' time, the poly available to us will be only highly cross-linked poly. So from that point of view, we will not have to really choose which poly to use. All poly tibia have again come back, and they are definitely economical. And obviously, because there is no undersurface, there is no undersurface wear. But you got to make sure that you will use them in patients who have a good quality bone, and they should have no defect. At the same time, you got to be ready that if they get infected, there is no liner exchange, you require a full tibia revision. So that you got to keep in mind. So generally, in a sort of patient with very good tibia and who wants to be having an economical option, you can go for all poly tibia, and PFC and Smith & Nephew have got a good all poly option. Instrumentation, I think, is extremely important because whenever you do a knee replacement, you got to have very friendly instruments. If the patient has got a flexion deformity and you want to excise a slightly more distal femur to correct the deformity, you should be able to do that in the instrumentation. If you've done the tibial cut and if you feel that, no, this cut is in slight varus and I want to change it, then through the same pins, if there is a jig available, you can put that and correct that varus. At the same time, you've done a whole bone cuts and soft tissue release, and you feel the flexion gap is still tight, and you want to give slight posterior slope to the tibia, you need to have a same jig going on to the same pinholes. Now, such things are available generally in Johnson and Zimmer. They have very good instrumentation for doing a total knee replacement. Mid-flexion instability gets talked about quite a lot, and sometimes I really feel whether this is a really overrated point, whether it is really that important. But you will see in the conferences, the mid-flexion instability crops up every now and then. What happens is during surgery, we check extension gap and flexion gap, and we feel the knee is stable. So at 90-degree flexion, the knee is stable. At extension, the knee is stable, but it may have instability at about 45 degrees. And that could transfer into a slight difficulty in getting up from chair or climbing stairs. So there are some implants who claim that they have stability in mid-flexion as well. Now, such implants, normally most PCL retaining knees are having mid-flexion stability. At the same time, Attune and Scorpio is single axis knee, and Attune has a J curve, a typical J curve in terms of axis center of rotation. Both these knees claim to be having mid-flexion stability. Availability of narrow size is very important because most of our patients, you must have seen, they have a slightly more anteroposterior length, but very little mediolateral length. That means they are slightly narrow as compared to most conventional implants. So either you end up oversizing, by that I mean that you are having an overhang on the lateral side, or you have a slightly tight flexion gap, or if you undersize, you will either notch anteriorly or will have a loose flexion gap. So in such a situation, having a narrow implant makes sense. Smith & Nephew and Persona have got an excellent option on this side. Now, patella-friendly implant is very important because not many Indian patellae actually are resurfaceable. And implants which have a good trochlear notch and a good Q angle are very good. I think Persona scores over other implants in terms of this particular point. Now, intercondylar bone resection becomes very important if you are doing a PCL sacrificing or a posterior stabilized knee. And most companies have become very conscious about this point now, and you can see that most newer evolutions of the same companies are having less bone resection. Typically, I think PFC will have a very large intercondylar bone to be removed. At the same time, Scorpio and the Attune will have very little bone to be removed. Sometimes we have very badly deformed knees, which may require a wedge, which may require an extension rod, and in your normal knee replacement, you should be having availability of these extensions very easily. If you see that if there is a varus collapse on one side and you require a bone graft to be put and you want to protect the bone graft with a tibial extension rod, it's important that your company or implant should be able to give that to you. And I think Johnson, PFC, Stryker and Zimmer, all three are very good on these points. Sometimes you may have to have a slightly higher constraint. You are doing a TKR, and in the same flow of your cuts, you should be able to add additional constraint. If you want to use a normal posterior stabilized knee, or if you want to use a constrained knee, or if you want to use a hinge, if you have to change your cuts, then I think you are sometimes fumbled. So in the normal flow of your cuts, you should be able to graduate to a higher constraint. And like this is a recurvatum knee, and it required a constraint on table. Again, I think the standard availability to us would be a good, the Zimmer, Stryker and Johnson, all three are having good flow for changing over from cruciate retaining to sacrificing to constraint to hinge on the same bone cuts. Sometimes you will be told that we have implants where you can change the constraint on table. Now, where it is required. Say if you are doing a PCL retaining knee, and at the end of trial reduction, if you feel that you have got an anterior lift-off, which means your flexion gap is tight or a PCL is tight, then rather having to do an additional bone cut or a PCL release, you can use a high flex insert, which has got a posterior slope, and you may be able to tackle this problem without any additional thing. Or at the end of surgery or trial reduction, if you feel that your PCL is slightly loose, but not that bad enough to go over to a PCL sacrificing or a stabilized implant, you can just go for an implant which has got a deep dish or a AP lip kind of an insert, and you can get out of this situation. Typically, a high flex insert will have a slightly more posterior slope, and a deep dish will have a less posterior slope. So trial reduction itself can tell you whether your insert is good enough to handle this situation. Now, this is just a small comparison, not that everybody would agree on this, but I feel that PFC scores over other implants where the instrumentation is excellent and revision components are very easily available. But they are not very patella friendly. At the same time, they are having mid-flexion instability, and they, generally the box that you have to remove is quite big. Attune has addressed that particular point, that they have a very good narrow size available. At the same time, mid-flexion instability has been tackled. The Persona has an excellent, it's one of the most patella-friendly implant, and they also have narrow sizes. NextGen has a very good instrumentation and availability of easy changeover to, say, higher constraint. Genesis has got narrow sizes very well, and they have a good change of consent on table without having to have an additional cut or any additional soft tissue release. Scorpio also has probably the least bone resection in a posterior stabilized knee, and it has tackled mid-flexion instability. Luckily for us, an implant selection is not a swayover that you choose one implant and get stuck with it for lifetime. But you can use an implant for a particular situation. Thank you very much.